the pelvic. Yeah, okay, right. So I'm today the lecture. Sorry, I got it late because I was having lunch and I completely forgot it. Right. Okay. So pelvic inflammatory disease, right? So so today at the end of the lecture, you should be able to describe what PID is and describe what the pathogenesis. So how you have to know all these lectures I have been doing this, that is understand the pathophysiology inside the body, what's happening, the pathologically as well as physiologically, what are the changes which are happening inside the body, so that you can correlate with the clinical features and then you can evaluate patient with PID, and then to describe if somebody gets PID, what's going to happen to that person, and what are the protective and the risk factors for PID, and the pathogens involved. Again, then we are going to do the proper clinical evaluation, touching the clinical pathological features, and then see what are the management options that we have if somebody is having PID, right? So what is PID? What do you understand by PID? Anyone? What is pelvic inflammatory disease? Anyone? So we have to quickly talk now. Huh? Let's say Arul Jenani. Yes. Yes. What do you understand by PID? Arul Jenani is not here. Yes. Yeah. What do you understand by PID?
It could be an inflammation involving the pelvic organs like uterus.
Okay, good. Yeah. So when you say inflammatory, there is inflammation. So pelvis, and they are right. So now, so if the infection in a woman, the infection occurs in the uterus, tubes and ovaries, overlying peritoneum, and parametrium, either side of the womb. So from the pelvis is an organ where there shouldn't be any organism. So if there is anything there which causes infection in the parametrium, the uterus itself, and the tubes and the ovaries, then we call it, and then because it's lined by a peritoneal cavity also, and so we call it pelvic inflammatory disease. And it causes, so when there's infection in the uterus and there will be inflammation, so inflammation we give a special name. So this is your basic pathology in your first year and in applied sciences stream. So endometritis, if the ovaries, if the tubes are involved, we call it salpingitis. And if the tubes and ovaries they get and there's pulse accumulation, we call it a tubo-ovarian abscess and pelvic peritonitis. So itis will come there, and so this is what we call by PID. So the infection is always usually ascending, and then the infection will go through the cervix canal, the uterus, tubes, and coming out from the tubes and ovaries, and then the underlying. So this is peritoneal cavity, and then the underlying peritoneum also. So when it becomes inflamed, the tubes and ovaries, and they all get inflamed, what we call the lining of the womb become inflamed, and then they change into pus, and the tubes also become larger, right? Edematous. And you remember all the classical signs of inflammation will happen in the tubes and ovaries and the uterus. Right. So the pathogenesis, as I told you, it's a ascending infection, and with time, so when when there is infection, there is increased blood supply, there will be bleeding, and all this will what you call the peritoneum get irritated, the what do you call the flat layer of the tummy, what is it called? Anybody? Start with O, which called the police in the abdomen. Anyone?
Momentum.
Great.
Momentum, very good, right? Because when there is any infection or anything, the body is normal. So the momentum will go and cover the whole thing, so that like in long years ago, when people didn't have antibiotics, when they were living in the caves, they have a severe abdominal pain, fever and all that, but the body tried to contain that infection within this thing, so the body has a chance of fighting, because if it is disseminated throughout the body, that person is going to die. Right? So this is what we see it when we do the laparoscopy. So usually the ovary, and then anybody know where this is? This is the liver, and there are, we call perihepatic adhesions. So what is this called? Anyone? So it's a classic inflammation. It's a pathognomic feature of pelvic inflammatory disease. Somebody have pelvic inflammatory disease, or if we see this in a patient in a laparoscopy or in open surgery, then we know that this patient had PID for sure, 100%. There's a term for that. Fitzhugh-Curtis syndrome, right? And then this is due to perihepatitis, we call it, right? So the liver is not infected, but the lining has got infected, and it's called perihepatitis, right? And we call it Fitzhugh-Curtis syndrome. It's a pathognomic feature of what we call acute PID, right? Now, when somebody gets PID at the initial time, it has high morbidity, because we call the acute time, right? Where there's a bacteria has gone in and it causes infection, and at that time, because it can change into a tubo-ovarian mass and pelvic abscesses, and it has high morbidity and sometimes even mortality, right? So in the acute infection state. But in long term, because everything get adhered together, there's adhesion, there's tubal damage, and even the lining of the womb get damaged. So there is a high risk of what we call tubal infertility. The tubes become blocked, or they can become narrow, and it results in ectopic pregnancy, and we call it chronic pelvic pain, right? The definition of chronic pelvic pain is if somebody has pain most of the days for more than 6 years and not related to your menstruation, we call it chronic pelvic pain. The sad thing about like this is very common, PID is common, and the complications associated with PID is common. But the sad thing is, if we identify early and if we treat early, most of the sequelae can be prevented. So that is why we teach you medical students this disease, PID, because majority of you are going to be GPs or practice in hospitals, where you see this patient, and if you don't recognize and if you don't treat this patient, their long-term complications are high. Right. So what are the risk factors for so if somebody's come, so you are like, the PID is a usually diagnosis of exclusion. So you have to suspect PID in a patient. So to suspect that, you have to know this patient has high risk factor, or this patient is high risk for PID because of these reasons. So what are the risk factors associated with PID? Right? Younger age, risk-taking sexual behavior, we are not wearing condoms, casual sex, and having multiple sexual partners, and sometimes when we put intrauterine. So, and remember, not all PID is due to sexually transmitted diseases like gonorrhea and chlamydia, or most of the sexually transmitted diseases can cause PID, but not all PID are caused by STI. So that is something you have to go home with, because I have seen this. When somebody say pelvic inflammatory disease, naturally a lot of people think, okay, that person has been promiscuous, no, she's somebody who has been sleeping around, that kind of feeling comes to you. So it should not be, because some of the things actually is due to what we call IUCD insertion sometimes, and we call it vaginal douching. So what that means is, in some countries they have scented and different type of vaginal cleaners or cleaning devices, and sometimes even solutions and all that to do. But the problem is they are chemical, so the PID becomes more of a chemical pathology, right? And also sometimes we just take a antibiotic, because in Sri Lanka we give antibiotic like Smarties, like there is no governance. So when you give antibiotic unnecessary, the good bacteria also dies. And most of the time in the vagina, there is lactobacillus. which is the good bacteria. And because it's acidic, it keeps most of other bacteria which are bad at bay. So it prevents these bad bacteria to become, to grow and, have a problem there. So, but if we take antibiotics, lactobacillus also dies. And if there's a resistant strain of any bad bacteria, they will start to grow, right? So anything which reduces the immunity, like tobacco smoking or any immunosuppressant drugs and all that, that also increases the chance of having pelvic inflammatory disease with one's own vaginal flora. Like the vagina is full of germs, so the bad germs are also there. So those can cause PID without any sexual activity even. So that's something you need to know when you have the correct risk factors and or multiple risk factors which may increase your chance of having PID. And similarly, there are protective factors like if somebody use barrier contraception. So barrier contraceptions or condoms are the only evidence to say that somebody can get protected from PID. And COC is combined oral contraceptive pills, or usually we know them as Mithuri, right, or the contraceptive pills. So they have a protective factor because it calms the peritoneum, reduce the immunity reaction. So it protects against PID, right? And also when the PID happens, it reduces its severity, right? It reduces, it becomes, abscess, adhesion formation, so that the symptoms and the problems are less if somebody is on OCP and get the disease. Right. So up to now, do you all have any questions? You all can drop questions in the chat box if you want to. Right. So we talk about the what is PID. We told that it's an inflammation or infection of the pelvic organs, as somebody correctly said. So pelvic organs here is from the cervix upwards, where the uterus, tubes, ovaries, and peritoneum and the parametrium, which are usually devoid of any bacteria. So if you have presence of bacteria, you can call it PID. And the problems with PID, we discuss about the acute problems, long-term complications, right? So we are going to talk about what are the causes, what are the microbiology of PID, right? So chlamydia and trichomonas. Now, when somebody talk about PID, the chlamydia is the gonorrhea comes into picture, right? But remember, it's only 30% of the time. So I have seen that somebody having an ectopic pregnancy, people think, that person has gonorrhea, chlamydia. Even if you do a Google search, if somebody has if somebody has an ectopic pregnancy, the first thing comes is PID. Now you can imagine a patient doing that, and then now she has an ectopic pregnancy, had removed the tubes and all that, and now let's say she has never slept with anybody else, and then she start pointing the finger at the husband. I mean, it could be that he has been sleeping around, but there's a 70% chance he wouldn't have. And this is not gonorrhea or chlamydia, which has caused her to get the disease, right? And cause PID and cause the sequelae of long-term sequelae of tubal damage and tubal ectopic pregnancies, right? But it's only 30% of the time, right? So non-chlamydial, non-gonorrheal upper genital tract infection is about 70%. So bacterial vaginosis, that's why we treat it. Aerobic vaginitis, right? And like especially with IUCD use, there is actinomycosis, which is a fungi, right? And sometimes tuberculosis. Now, last week I saw a patient who had PID with severe PID, actually with a lot of tubes and everything damage. And when I saw the lesion, I thought it's a cancer, but apparently it came as tuberculosis, right? So what we call extra pulmonary TB, right? And very rarely, not seen in Sri Lanka that much, or it's very rare, but we have seen this in patients who are coming from Middle East countries. So Schistosomas is a parasite which usually lives in the Middle East countries, so they can get that disease. And so you have to keep that in mind, especially if you are examining a patient. In the history says that he has had a visit to Saudi, the Middle East country, then you should be able to you should suspect even schistosomiasis. Okay, so I'm going to go offline. Right. Okay. Now the clinical evaluation. So far we talk about the pathogenesis. We talk about what happens inside the body when somebody get PID, about the sequelae, about acute infection, long-term complications, including ectopic pregnancies, tubal damage, and tubal subfertility, chronic pelvic pain, and these kind of problems. And then we talk about the possible pathogens involved in causing PID and the clinical evaluation. So patients usually coming with a spectrum of diseases. They can be asymptomatic to symptomatic. When they are symptomatic, they come with either tummy pain, lower tummy pain, vaguely, or there are specific, right side adnexy or left side adnexy pain. When we sometimes examine, you can see a fullness on the adnexy, and sometimes there's a tender mass inside the body. When you do a pelvic examination, you see a tender mass, and sometimes you suspect it when you do not suspect it when you do a laparoscopy. You always check the liver, and you see what you call Fitzgerald's QT syndrome features. Then you know that she's had that PID in the past. So the presentation is usually pain, vaginal discharge, sometimes fever, and sometimes they are menstrual irregularities. They can have heavy menstrual bleeding, they can have frequent bleeding, they can have irregular bleeding. So all this can cause. And if somebody has a nicely, cycles and then suddenly become change, you have to think about PID. Right, so the pain can be low abdominal, right upper quadrant due to perihepatitis, what we call Fitzgerald's QT syndrome. They can present with dysuria, like urinary tract infection, and what we call deep dyspareunia, right? And they can present with vaginal discharge, usually offensive. They can have fever. They can have abnormal, including post-menopausal bleeding, post-coital bleeding, instrumental bleeding, intermenstrual bleeding. So which are irregular bleeding and postcoital bleeding are common with somebody who's having PID because of the inflammation. Right. So HIV is very common nowadays. A lot of people with HIV live a very normal life now. So sometimes if you are not told, you don't know that they have HIV. However, if they have AIDS and if they are having immunity down, then if they get PID, there's a high chance they will end up with a pelvic abscess. And sometimes we need prolonged hospital stays with antibiotics for prolonged periods to counteract that. And HIV patients, because the body's defense is not that great, their action to antibiotics is less, right? And we may have to go for very high-fi antibiotics. We call it like piperacillin, tiorbactam, and things like that. And usually we require IV antibiotics because we are not going to wait and see. Right, so I told you contraceptive pill is a protective factor. So if you ask from the patient, she said, I was on the pill for the last 6 months. You have to rethink about your diagnosis of pelvic inflammatory disease, or maybe it was very severe. Now, after starting the medicine, she should get better, right? So as I told you, if you take estrogen pills, it acts as a barrier against PID in the pelvic organs, right? And the retrospective study, so when patients had chlamydia and all that, when they look at it, they found that endometritis and cervical infection, they can be masked by OCP. And then, so when you take chlamydia infection, antibiotics, so the only problem is if you're taking OCP, that may interfere with the drug's availability. Right, so if somebody gets PID and if you don't treat, the tubes can get damaged because it starts to ascend. The infection will start from lower vagina to upper vagina to the ovaries and tubes and ovaries all. right? So they can have tubal infertility. I talked to you about ectopic pregnancy, chronic low abdominal pain. And if once have an ectopic pregnancy, the chance of ectopic pregnancy once is 5%. And if they have 5 to 7%, and then if they get it repeated infection on the same tube, they can go even up to 40% of accreta. And so it's dangerous, right? Now, when you examine, so now if you examine and there's unilateral pain, it could be a cyst, it could be hemorrhagic cyst, so many things, right? But if they have low abdominal pain very vaguely, that's usually indicate PID, right? And when you examine bimanually, you do a pelvic examination and you try to press on the either side of the adnexy, they will have adnexal pain. And there can be pain during what we call motion, cervical motion tenderness, right? And also they can have fever, especially more than 38 centigrade or more than 100 Fahrenheit. And that time you need to come to the hospital immediately, right? So what are the take home message? As I told you from the last class, all women are pregnant and has an ectopic pregnancy until proven otherwise, whether it's IUI, IVF, time intercourse, natural intercourse, whatever. If the patient comes to you at early gestation, it's your duty to assess her properly and exclude an ectopic pregnancy. And if there's ectopic pregnancy, do it. So when somebody is coming with low abdominal pain with a period of gestation, let's say she's 20 weeks now. So the things which crosses to our mind, ectopic pregnancy is unlikely unless it's abdominal ectopic pregnancy. Acute appendicitis is common. So that's one of the areas Prof. Sanjeev excel. And endometriosis and complication of an ovarian cyst, torsion, rupture and all that. So you need to think about all these causes if somebody coming with abdominal. So now we had a case presentation just before you all. So it was a classic symptoms of PID. So you have to know this and then only you will take her through it. And even urinary tract infection can happen, and functional pain or what we call mechanical pain is very common with pregnancy. With the advancement of the pregnancy, the back pains, the tummy pains can increase. Right? The problem is we can't diagnose, there's no diagnostic test. Even if you find an infection, it doesn't mean that the patient has PID. Right? So it is also important. And just because there is absence of organism, it doesn't mean that she doesn't have PID also. So sensitivity and specificity is low, right? And however, we can do a chlamydia test. If it is positive, we have to think about gonorrhea and the elevation of ESR and CRP levels, right? Which are what we call secreted when the body goes into hyperdemic situation. So these are very useful markers to see whether this patient is having an infection, right? And so when we do what you call scraping, there is no cells, and that's also increase the chance of PID. Right. So if somebody is diagnosed PID, what are we going to do? So the main take-home message is, if there's somebody coming low pain, abdominal pain, there's vaginal discharge, you think of PID, you treat PID, and usually it's for 14 days. So there are criteria, and you may have to give hydration with IV fluids because she may be vomiting, and antacids, anti-vomiting medication because she's having what you call so if you suspect PID, you have to treat PID, right? So you think this is the PID, you have to treat PID. You may not be even treating PID, you may be treating something else, but it doesn't matter. This is one of the rare instances in medicine where we say use antibiotics empirically, right? But there are criteria for intravenous treatment. If they have a very high fever, signs of tubovarian masses, pelvic peritonitis, sepsis, we have to do it, right? And once we are started treatment, they should avoid sexual intercourse until we advise. And when somebody has PID, you have to always talk about the sequelae, right? What will happen to if she gets a second time? What will happen to her ovaries? If she gets a third time, what will happen to her womb and all that? You have to have a discussion at the time of the diagnosis. Right. And severe PID, as I told you, IV antibiotic, but otherwise we give a very flexible regime, Ceftriaxone 500 milligrams, and followed by doxycycline 100 milligrams twice daily, plus metronidazole 400 twice. That's the lowest we can give. And about 80% will work on this. Right? Now, if there's a big abscess, we try to drain the abscess. And sometimes if everything mattered together, and that is the one which causes pain, we might have to go and do what we call adhesiolysis. It's a difficult surgery, but sometimes we have to do it depending on the patient's condition. Right? How they can right, so he has asked, he or she has, sir, what is aerobic vaginitis? So like anaerobic vaginitis is common, which is inside the vagina. So this is slightly outside, which they need oxygen, right? The organism needs oxygen. So if there is a mechanism to support that, we call it a aerobic vaginitis. If it is not there, we call it anaerobic vaginitis. Sir, what is the basis of absence of endocervical and vaginal pus cells? So that's mean it's so the vagina and the endocervix can have infection because it's anyway open to the environment and there can be infection. So we don't call it PID, but above the internal loss, rest of the organs should not have any infection. So if there is call, we call it PID. Right? And you have to always talk to the patient and say that you are going to take a medicine for 14 days, which is very difficult, right? So you have to have alarm, and soon after you wake up, take the 4 tablets and then go back to sleep and wake up at this time and start eating. And at evening also, before dinner, if you're having dinner at 8 o'clock, have the medicine at 7 o'clock, and 5 to 7 also only water, 7 to 8 also only water, right? And if somebody is having an infection, it's better to always screen the sexual partners to see who has the disease and to treat that person. Right. So in summary, what you have to realize is PID is a very common disease, right? And it can have a very serious post-infection sequelae, including tubal block and ectopic pregnancies and further miscarriages. And we have to have a lower threshold for treatment, and especially fertility treatment. And barrier methods can prevent having, so asked to practice condoms regardless of what's the contraceptive device that they are using, and if they are not sure about the partner, right? And the proper patient advice, right? And we go by a small principle. If you find PID, or we search for others and treat for all. So I don't know whether when you are in the STI that was said to you. So in our time, it's if you find one, search for others, treat for all. That is how we went. Even if we can't find, we treat for all. So this is what we do. So all the anaerobics will be dealt by metronidazole. All the aerobic will be dealt by the other medication, right? So that's why we give 2 medicine for 14 days. It's prolonged course. Right. So homework, read these 2 articles that give a very comprehensive idea about the management. One is from the Sri Lanka College of Venereologists. The other one is from our department. Any questions? Okay, thank you. Any questions?
Excuse me, sir.
Yeah.
Sir, do uterine fibroids increase the risk of PID, sir?
It does not.
Okay, sir.
right? So when you have fibroids, when you are testing for fibroid, you may get PID, but not the other way around.
Okay, sir. Thank you.
Any more questions?
Sir, I have a question, sir. Sir, what is the core basis? Like, why do you get postcoital bleeding in PID, sir?
Not per se, but one of the commonest cause for secondary postpartum hemorrhage is infection. So when you have PID, there's usually infection, and it can infect the ovaries and tubes also. And when it can infect the endometrium and the myometrium. So if that happens, they start bleeding. Okay.
Excuse me, sir.
Yeah.
If a diagnosed patient with PID has several risk factors and has a risk of recurrence in the future, is there anything we can do for prophylaxis or something like that?
So at the moment, the possibility is only two things. No, like there's no point giving prophylactic treatment. We have to know, but we have a lower threshold. If somebody says abdominal pain, even we have not taken cultures and all that, we think whether it is PID and start treatment. Yeah.
Okay, thank you.
Okay, then. Thank you very much. Sorry for being late, but I compensated for that by doing the lecture a little fast. I don't know whether it was too fast. Yeah. Okay. Enjoy the appointment. See you. Bye.